Good afternoon. I want to thank the symposium organizers for inviting me to present on our work at the University of Miami regarding the role of MR imaging in the management of this uncommon patient population. I have nothing to disclose. The purpose of our work is to determine the feasibility of quantifying signal changes in superficial fibromatoses using radiomics and T2 mapping. And specifically, when we refer to superficial fibromatoses for this discussion, we're talking about the hands and feet. The fibromatosis involves the proximal palmar aponeurosis, we're referring to Dupuytren's disease, and similarly with involvement of the flexor tendons of the feet and the deep plantar aponeurosis. In that location, we're referring to Ledderhose disease. Our hypothesis was centered on treated lesions exhibiting a lower T2 relaxation time and displaying different textural features after treatment than prior to treatment. Again, our background on this research centered on treated lesions exhibiting lower T2 relaxation times than untreated lesions, in particular regarding the textural features or radiomics. And a beginning of this presentation and others for the last several days, focusing on Ledderhose disease and Dupuytren's disease. We at Miami were looking at the division of the entity as nodules in the palmar or plantar fascia involving decreased T2 signal intensity. And this is in particular of the proliferative stage where the fibroblasts are multiplying, forming benign fibrous nodules and cords, and of course beginning to lay down the collagen. It's at this initial proliferative stage where we felt our MR imaging was particularly sensitive in identifying the activity that could be amenable to definitive radiation therapy. We have published previously in 2018 in Skeletal Radiology, our initial University of Miami experience that demonstrated the value of T2-weighted MR imaging in the treatment of patients with Ledderhose as well as Dupuytren's disease. And in particular, our 10 patients had 37 nodules, and all patients were treated using Dr. Sagenschmidt's Essen experience of the split course electron beam therapy, usually involving 6 to 9 MeV. This delivered 30 gray over 10 daily fractions with a planned 12-week break between fraction 5 and 6. We did the post-treatment MRI about 3 months after fraction number 10. Other investigators, Fukawa et al., prior to our publication, had been working with T2 mapping, allowing a quantitative assessment of collagen content in a rabbit model. And their work showed decreasing T2 values also correlated with histologic tendon healing. Thus, our most recent publication in 2021 updated not only our patients getting MR T2 evaluation of patients getting radiation for Dupuytren's and Ledderhose, but also we were applying this T2 mapping concept using a single slice region of interest for the dominant nodule in the hand or foot, and then using commercially available software that you see listed there from Germany to run this program. I have to especially acknowledge my colleagues um, who helped in developing this project and the latest publication, in particular, Tai Subawang, who really has the institutional research protocol for the T2 mapping of patients with benign superficial fibromatosis. The most recent study involved 19 patients and looked at 27 different lesions, although unfortunately we did not have T2 mapping for all the patients. And I will specify where the T2 mapping was done versus just the evaluation of the T2 relaxation times of pre and post irradiated patients. Our MR protocol involved essentially T2-weighted MR, looking at the nodule versus muscle or tendon reference. Sometimes we interchange proton density weighted MR, but basically it was the T2 mapping sequences. And it involved the elongation times that you see listed there. Our radiomic features of the T2 mapping involved, in particular, Shanton's entropy, kurtosis, skewness, mean of positive pixels, and uniformity of distribution of the positive gray level pixels. Just for those who may not be as familiar, the skewness is a measure of the asymmetry of the histogram for these relaxation times, and essentially a conversion from a normal distribution to a skewed or asymmetrical distribution. And then entropy, which obviously is borrowed from physics, which is the disordered randomness of the gray level distribution for the pixel orientation within the image in this instance. From our original 2018 publication, we did show how we graded with Dr. James Banks, who at the time was our fellow in musculoskeletal radiology. And you see we developed a 1 through 5 ordinal scale regarding T2 hyperintensity. In that original publication, we also looked at contrast enhanced and found that that really didn't add. So we have just dropped the contrast and just done plain MRs looking at T2 hyperintensity using the 1 to 5 scale, with 5 being equal to vessel activity and 1 being more equal to the bony cortex, 3 to muscle. And then you see there 2 is between the bony cortex and muscle, and a grade of 4 would be between muscle and vessel. And again, all patients had their post electron beam therapy MRI about 3 months after fraction number 10. So essentially about 6 months after the pre-treatment MRI. This just mentions our protocol that we use in particular for the T2 MRIs with a slice thickness of around 3 millimeters and our resolution or matrix in the 300s. The standard protocols that people may be employing for MR were all over the place, and we've tried to standardize this for our patient population. So for the actual T2 mapping of all of our patients, 7 subjects had the pre and post MRI T2 weighted and the T2 mapping. And then this just shows some of the techniques that was used and how the map was derived from this pixel-wise mono-exponential non-negative least squares fit analysis using the software from Germany. And the acquisition time for the T2 mapping sequence was about almost 6 minutes, 43 seconds. Just to go back from our original publication in 2018, this shows our typical setup of electron beam for our Dupuytren patients. I've developed this customized vac fix technique with the patient being simulated and treated with arms above the head. And you can nicely fixate and reproduce this and maintain the vacuum locking device for the 3-month hiatus and then restart the patient. You see I projected the light field and we have our lead cutout that you see outlined. This slide just represents the typical setup for my Ledderhose patients, which is feet first in prone position. And you see, just like we would traditionally do, we would wire the fibroma and then a 15 to 20 millimeter normal tissue margin around the patient, and then do thin cut CT images. We then will fuse with our CT imaging the MR that we've done pre-treatment on the patient, and then also with the radiopaque delineation of the fibroma or nodules and the normal tissue margin, come up with a reasonable plan that involved typically 6 to 9 MeV with appropriate bolus that we would place at the time of CT simulation, which was predominantly 5 millimeters. This just shows one of my patients pre and post treatment to the thenar eminence, and you see the lost pigmentation, sort of a flattened appearance. And in our original 2018 publication, we did show that the T2 weighted MR and the contrast enhanced MR, as well as symptomatology and reduction of the tumors or the nodule size, all correlated. Yet we found that MR imaging was the most accurate and reproducible. This is a accident MRI of the hand of one of my Dupuytren's patients, again, over the thenar eminence. And on your left, you see the outline arrows, the pre-treatment T2, and on the right, the post-treatment T2, and the T2 intensity was a more pronounced than the change in size, which was the point I was trying to make. This sagittal MR of one of my Ledderhose patients shows pre-treatment T2 weighted imaging on the left, and then the post-treatment T2 imaging, where you see more than the size, although it was some reduction in the thickness of this fibroma in the midfoot of the patient's foot, but the intensity was significantly reduced. This is our results of our 2021 patients showing a decreased T2 signal ratio between pre and post treatment, which were for all of the patients, not just the patients we did the T2 mapping. And again, we show the increase, if you will, in the T2 skewness for all the study patients, looking at T2 skewness and entropy decrease. And this was the two most important findings of our current study. Here is a pre-treatment T2 mapping of a Dupuytren study patient. And again, you see in the bottom right side of the slide, the normal distribution, which was basically 0 or minus 0.1. And then on the follow-up, you now see the increased skewness of 1.4 of that lesion, even though the size may not be significantly affected. So our T2 mapping, again, shows the decreased T2 intensity gradients on our patients when compared to tendon or muscle. And now this shows actually on the right of the slide, the T2 mapping gradient, which is very similar to a heat map if you were doing genomics, for instance. And you see the lesion that's on your left is in the greenish area. So we are selecting patients when we do the pre-treatment T2 mapping that have at least moderate to heavy increase or uptake on the protocol. If they're cold or in the blue, we are tending not to offer radiation therapy. So we're not only using this process for evaluating our patient's response to therapy, but also for selecting patients. Here shows the follow-up T2 mapping that we did. And on the left, you see the lesion. And on the right, you see how it's now cold or blue. And you see there the T2 decrease from 55 to 41 milliseconds. This shows a baseline T2 mapping of one of my Dupuytren patients. You see the lesion outlined on the right of your slide. And then you see it is that greenish, there is a little bit of blue, but we did offer the treatment to the patient. And then you see the follow-up T2 mapping, which permits the quantification of the T2 relaxation time. And you see there that it is heavily blue or cold, with the T2 decreasing from 46 to 28 milliseconds. This slide again shows over our patients, all the study patients having decrease in T2 relaxation time. So therefore, our MRI, radiomics, and T2 mapping, I think we've demonstrated is feasible, and they provide novel biomarkers, both for responsive electron beam. You see there also for using in selection of patients for electron beam therapy. And then you see that the lesions responding to electron beam therapy, again, with the radiomics, we see a T2 signal decrease from lesion to muscle ratio. The absolute T2 relaxation times can be determined and they decrease. We see that skewness, that radiomics parameter does increase, and the radiomics parameter entropy decreases. Of course, we realize we have limitations. We have a small sample size, and we're looking mainly at the largest representative region of interest. So smaller nodules aren't, we aren't able, or we aren't trying to map at this point, although we're looking at ways of doing that. Obviously, we weren't blinded to whether or not the patient had a pre or post MRI, post-treatment MRI, and of course, we have variable follow-up. Our future directions, further investigations, we think are at least warranted to determine the reliability of this T2 mapping and determination of the skewness and the entropy for predicting response to patients with benign fibromatosis of the hands and feet for undergoing electron beam therapy, and for ultimately selecting the optimal patient population, which is benign disease, to give ionizing radiation. Thank you for your attention.
Thank you, Dr. Wolfson. The first question is, why did you use electron beam therapy and not superficial X-rays for Dupuytren's and Ledderhose disease?
Thank you. And I also want to apologize for calling one of my Ledderhose patients Dupuytren's. I noticed as I was going through it. So as far as the treatment, we only use electrons. We don't have superficial radiation.
Okay, thank you. Next question, do you ever radiate patients with nodules having T2 mapping, studies indicating a low T2 relaxation time?
Not anymore. When we've developed it out, and I just had a patient recently who we did, she had Dupuytren's disposition, so both hands and feet were involved. The feet, there was medium uptake on the T2 intensity, and the hands, it was cold, so I'm only treating her feet. The patient has sought a local radiation oncologist to treat her hands, but I told her I wasn't comfortable with our data in offering treatment if I didn't think I had a reasonable chance of helping her.
Okay, thank you. And final question, what do you do if patients have increased nodule size that's, pardon me, outside your electron beam field after the 3-month planned break?
So this has happened only once or twice. When the patient came back, and I put them, I always, in initiating the second phase of the split course treatment, and I put the light field on with the vac lock, and 1 or 2 patients have had the nodule that had grown, if you will, outside of the light field. So what I did was I made a new cutout, and obviously I gave 5 fractions to the enlarged volume or region treated, but rather than putting the patient on another 3-month break and giving the final 5, the area of overlap was very minimal. So I used the second part of Dr. Sagenschmidt's original Essen trial, and I just give 7 fractions on that split course regimen. So that way I get 21 gray to encompass the new area. And then of course you give 2 extra fractions. So it'd be, I guess, 36 gray to the whole area, but at least I feel that's reasonable to use.
Okay, thank you again so much. With that, on behalf of Extra, I'd like to thank you for your attention, and I will conclude the session.